is get into your ASICON apps, if you can please do so, and press the quiz area, the quiz button, and hopefully we would go, there are some questions that I would like you to answer. They come right through the talk today, so just keep your eyes open when I say please vote, please vote. Does that make sense? And just submit it. Don't just vote and not submit it. All right? Are you okay with that? Yeah? I want a loud yes or no. Yeah? Thank you. Thank you, Ed. And should we start off?
Right, I was just saying, I don't know if you have the Duracell battery handle over here, which we have in the UK. But it goes on about staying power. I don't know how you do it. I mean, you've been here since 8:30 this morning, and no tea breaks. Tea breaks were cancelled. So it's fantastic testimony to your desire to learn more. Anyhow, this is going to be a quick session, which Jyoti and I are going to do a little dual act on. And so I'll get straight into the first patient. And some of the questions are very easy. And I'm going to do a little bit of review in the middle of it quite quickly, because it's so late. But we have a 37-year-old man who came from sub-Saharan Africa, and he was perfectly well. He had a focal fit. And at that time, he'd been having fevers, he had a headache, and he went to his GP, and the GP was on the ball, urgent CT scans, same day, and got the phone message back saying, this shows what I think is a glioma from the radiologist. She then organized a rapid appointment with the neurologist, but the patient thought, hang on a moment, I come from Africa, there's a real risk I might have HIV. So he nipped down to the sexual health clinic and got himself an HIV test, which was positive. Went back to his GP and said, does that change things? And she said yes, and was admitted under my care. So on examination, the only additional feature to the fact the patient had a fever is that they had some weakness in the left lower limb. And you've got a CT scan there, which you can see. And so we move on to the first question. Oh, I do that. What is your diagnosis? And here are the options. You can read them. All right. Toxo, meningitis, TB, tuberculoma, basically, primary CNS lymphoma, a cryptococcoma, PML, or something else.
Please vote.
So you have, I'll count down from 10. So 10, 9, 8, 7, 6, like blast off, isn't it? 5, 4, 3, 2, 1, half, 0. So can you?
Yeah, well, I don't know. Is anything, it's there, yeah.
Oh no.
Tarun?
Do we know the answer? So does it come up? Ah, well, anyhow, good fun voting. Is there any way it can?
Tarun?
No, it's just information.
Okay, let's move on.
Jyoti and I thought something else might happen, but anyhow. So you all know the answer. You think it's cerebral toxoplasmosis. So the next question is, what are we going to do about this? Are we just going to go straight in and treat and organize an MR scan? Are we going to hold off with the treatment and organize the MR scan?
Are we going to, we were going to vote here as well.
Yeah.
Is it possible, Tarun, at all? Okay, let them...
read it.
No, let them vote while you're reading it, please.
Ah, right, excellent.
Oh my God.
Does that come up?
Yes.
Success. I can't read it, though.
Okay.
Okay, let's just go back. I think...
most people have voted for...
tuberculosis. Well, I mean, it's common here, so I can understand that, and I think we get another chance having a look at the MR scan in a moment. Toxoplasmosis, I see, is the third likelihood, which is surprising, but you don't have a CD4 count, and, you know, I can understand that, but it is the most common cause of somebody with a focal fit and a fever and a short history if they have a space-occupying lesion, which the CT scan shows they obviously do. Okay, so the next question I said to you was, what are you going to do? Are you going to treat for toxo, organize an MR? Are you going to wait before you start treatment for toxo, still organize the MR? You've got the questions up there. Are you going to treat for TB and try and confirm the diagnosis, maybe a CSF? Are you going to treat for toxo but only get an MR scan if the patient deteriorates or something else? So vote now. So when everybody's had a chance, okay, let's get the answers. Do they come up pretty quickly this time?
Darren?
Wow, excellent.
Excellent.
Okay, nothing I can teach you. So there you go, there's the MR scan. You can see a large amount of edema around on this cut, a single enhancing lesion. It's not classic ring enhancing, but it's certainly enhancing a lot. And the edema which is prominent, and that is pushing the midline across, so you have midline shift. The patient was started on antitoxoplasma therapy and the patient responded. So the clinical challenges are diagnosis. How do we diagnose it the most accurate way, if we can? Optimal treatment, when to use steroids, when to biopsy, what to do about persistent changes. Or to put that around the other way, how long do you wait before you consider getting a biopsy if you have persistent changes despite the patient getting better? When to start HART? You start it immediately, at 2 weeks, at 6 weeks. When do you start? And when you get that situation, when you started HART and they get a relapse of their symptoms, how do you distinguish ARIS from an actual relapse of the infection? So I think you know this. Toxo, typically you have fever, focal neurology and confusion. About a third of them have fits. It's a shorter history than, say, you get with primary CNS lymphoma, and certainly against progressive multifocal leukoencephalopathy. CD4 count usually under 100. Rarely do you see retinitis. I've never seen encephalitis coexisting. But the MR scan is critical, and the MR often is the way you make the diagnosis. But it makes no difference if you have a space-occupying lesion or multiple space-occupying lesions. You would normally start with treatment for toxo as you try and confirm the others, because it is the most common. So toxo on scan, usually it's multiple lesions you see. It's prominent ring enhancing, and I've got another scan here of the cortex of a lesion there, and you can see the enormous amount of edema, and you can see the ring enhancement, classic ring enhancement. You also get them in the basal ganglia and the brainstem commonly. You can get them anywhere. Normally you see 3 or 4 lesions. This patient I've just described only had the single lesion. And compared to a CNS lymphoma, they are usually homogeneous in their enhancement. They are usually periventricular, as you can see here. They can be anywhere in the brain, but they are, as I say, usually against the ventricle wall. Here's what happened to our patient. You can see after 2 weeks treatment, there's been a significant reduction in the edema, although the lesion looks pretty similar. And this is somebody with primary CNS lymphoma, which I just showed you. And after 2 weeks toxoplasma therapy, there's no change at all in the enhancement. So just one other thing to say, that the CD4 count can be really useful. Now, in that first patient, the CD4, I think, was about 100. This patient had a CD4 count of 870. So that is not going to be toxoplasmosis. And when this Zimbabwean lady, when we actually get to getting her serology results back, she has cysticercosis with very strongly positive TNA solium serology. So the important thing is the CD4 count. So use that whenever you can, because that's going to rule out certain possibilities. TB was the one that was thought as being the most likely, and of course TB can occur at any CD4 count at all. When do you get CSF? Well, you get it when it's safe to get. The first patient had midline shift, so you wouldn't do it then, but we just speak to the radiologist and confirm with them whether it is safe to get one or not. The actual PCR, toxoplasma PCR, which I'm sure you can get here, has about a 95% sensitivity and about a 95% specificity. So if you have it, it's a good chance that the patient has toxoplasmosis. But also the reason to get a CSF is because you can exclude other diagnoses, especially primary CNS lymphoma. What is the place of steroids? Steroids you're going to have to give if there is midline shift or tentorial shift. But you try and avoid it if you can, because it can muddy the waters. Because a patient with primary CNS lymphoma also has a lot of edema. The edema will settle, but of course the patient still has the lymphoma. And you get the misimpression that the patient is actually improving when they're not. So what about a biopsy? When you do a biopsy, when therapy has failed, when there's a reliable history, the patient's been taking their Cetrin, when you take away the steroids and the lesion sort of comes back, or the symptoms come back, when there's one lesion and it's atypical, and when you have a high CD4 count. So this patient had a CD4 count of 333. I'm not going to spend much time with it, but there's a lesion there which is atypical for toxoplasma. Her CD4 count is high. It's in an atypical area, and the second MR scan was no smaller, it was bigger, it was biopsied, and it was aspergillus. So do biopsy if things don't seem right. Don't assume it's toxoplasma. And of course, with tuberculosis being so common, it could be tuberculoma, but that is very big for a tuberculoma. But if there is a possible tuberculoma, you would be doing a CSF, you'd be looking for tuberculosis. And usually they are multiple. So what is the optimal treatment for toxo? There have been several studies, but nothing recently. So it's either sulfonamide, which is sulfadiazine with pyrimethamine, or clindamycin with pyrimethamine are the number 1 and number 2. And pyrimethamine, when you give it with sulfadiazine, is more active in the studies, but it causes more side effects. On an intent to treat analysis, there is no difference between the two treatments. And if you look here at one of these, you can see that their mortality, it's the probability of disease progression, is much greater if you use clindamycin with pyrimethamine than it is if you use sulfadiazine. But the number of side effects that you get with the sulfadiazine means, as I say in an ITT analysis, they come out the same. I would always use sulfadiazine with pyrimethamine as my first choice, and only switch if there is a problem. K-trimoxazole is a useful alternative to sulfadiazine or clindamycin with pyrimethamine. And you should get improvement within about 5 days, although the scan may not improve for a couple of weeks. What about the persistent scan? So this is a patient who was referred to us when they made the diagnosis some time after they treated him for a bacterial abscess. And you can see that over a period of 4 and 8 and then 6 months, there was very little change in the actual lesion, the periventricular lesion. So the point here is the scan can remain abnormal for a prolonged period of time. And when it's a lesion as big as this, it can remain abnormal for life. So here's the next question. When would you start ART in somebody who's got cerebral toxoplasmosis? Immediately when the patient has been diagnosed, and they come in with a space-occupying lesion, would you start them then, as you start them with toxoplasma treatment and you sort out an MR scan? When they're established on their toxoplasma therapy, about 2 weeks or around 2 weeks, so I think B, once they're on in the first week, then around 2 weeks, not much between B and C there, and D, when you've completed toxoplasma treatment at 6 weeks, and E, not before 3 months. So why don't you vote now?
Vote, please.
Vote, please. It's not long, all right? First case is nearly finished. Okay, let's have a look. Oh, hasn't come up yet. We're ready? So around 2 weeks, and I don't think I'd treat immediately, all right? I think starting ART, when you have somebody with a lump in their head, or you have cryptococcal meningitis or TB meningitis, I think you regard the possibility of ARIS and the damage that ARIS can cause if you start them at the same time as being much more significant if it's a CNS problem. And so for cryptococcal meningitis, I think all of you would say, well, you'd wait probably 4 weeks, 3 to 4 weeks. And for cerebral toxo, I would always wait at least 1 to 2 weeks before starting treatment, but not give it immediately. And also, you're giving a lot of drugs at the same time. ARIS, very difficult to distinguish what is ARIS from a relapse of their infection. You've got somebody here with pre-treatment, week 1 with the edema settling, and then week 6 when they've come back, and you can see a bit more midline shift. If somebody has had good adherence, if they haven't had a rapid CD4 count increase, and if there is significant edema, quite often that is related to ARIS, but you may need to do a biopsy. And that's it. I don't know if there are any questions regarding that case history. Please, any comments? I know it's terribly late.
Any questions that anybody wants to ask regarding this case? Last slide.
You want to ask later?
No, the last slide. Can you go back to your last slide, Ed, please? What about the last slide? Sorry, would you like to come to the mic and tell us?
Actually, toxo-ARIS is uncommon. It's not like other CNS diseases, not like tuberculosis, for instance, where it's much more common.
Rapid CD4 rise.
Rapid CD4 rise. Well, that's true of all ARIS. It's what's been found in sort of observational studies. I don't think it's a strong predictor, but it is a predictor.
Any other question? Sorry?
Okay, you still with us?
Still with us? Okay.
Do you want one more?
Next case?
Okay.
Yes.
Do you want to do your hepatitis?
All right, do it quickly.
A 42-year-old single female, no significant past medical history, fever, sweats, generalized lymphadenopathy, chest X-ray normal, CT thorax, I'll show you, and CT abdomen, I'll show you. And you can see the millet-like seeds on a chest X-ray, so the miliary pattern there, you'll take my word for it, she's got big abdominal lymph nodes. And you do not have to be a rocket scientist to work out what's going on. Terribly anxious lady, and didn't want to have an HIV test, but she did agree in the end. And it was positive, CD4 count 147, high viral load, wild-type virus, and Hep B and Hep C negative. That's important because we're going to talk about what treatment to start her on. TB screen shows induced sputum positive for AFB, and the MTB probe is positive, and it's rifampicin and isoniazid probe negative. So this lady went on to standard anti-tuberculosis quadruple therapy. She'd started cotrimoxazole for PCP prophylaxis before then. Then she starts a RHZE, and then 7 days later, she goes on to efavirenz, tenofovir, and 3TC as a single tablet regimen. So 1 week after commencing the HIV treatment and 2 weeks after the TB treatment, she gets a rash, she spikes a fever, she gets hepatitis with the ALT going up to 2.5 times the upper limit of normal, and for us that's about 100. She has mild eosinophilia, having previously been normal, and her chest X-ray shows much worse miliary changes, which were not visible on the initial chest X-ray when it was only seen on the CT scan. So the question is, what is causing this rash, this eosinophilia, and this hepatitis? Is it the TB treatment? Is it the HIV treatment? Is it the Cetrin? Or is it the ARIS? Vote now. So you've answered already. Is that C and D? TB or D? We're going to get a vote.
Go on, vote, guys, vote. It's not working.
Ah, right. Well, would ARIS give you a rash like this? And when you say ARIS, what do you mean? You mean ARIS to the TB? I mean, that's what you're talking about, aren't you? Would you get a rash? Yes, hepatitis. Yes, fever. So you think it's a cotrimoxazole rash and ARIS causing the okay, and the eosinophilia again is due to the Cetrin. Good, I've got it. We'll carry on, perfectly reasonable. So which of the TB drugs, if it was just one thing and the TB drugs, who's going to shout out what the most likely drug is, and you know this better than I do, that is likely to give you a rash? of isoniazid, rifampicin, ethambutol, and pyrazinamide. In the studies, which is associated with the rash most? Anyone? No, it's ethambutol, actually. Rifampicin is least likely to give you a rash. And I know it's flipping confusing. So TB drugs and hepatotoxicity, all right, we know that INH is the most likely. Rifampicin obviously gives you elevations. Quite often alphos is elevated mildly. ALT, yes, but INH is the one that's most likely to give you a rip-roaring hepatitis. And the most important thing when it comes to reinstituting drugs is ethambutol is rarely the cause of the hepatitis. So the rash is ethambutol the most likely, rifampicin the least likely, but remember you can get a good going Stevens-Johnson or DRESS syndrome with any one of these antituberculous drugs. And if you get that, you're not going to be using any of these drugs again because it would be too dangerous. So the HIV drugs, which one? It's obvious, isn't it? Efavirenz is the most likely drug to give you a rash, to give you hepatitis, and it could give you eosinophilia. So what would you do? Well, this is what I did, just to speed things up. That's all right. It's a long day. We all got to let off a bit of chat. Cetrin was stopped, agreeing with the lady there. She was switched to atovaquone, not giving her dapsone. We gave her some antihistamines. We stopped the efavirenz, or I stopped it, but for the moment, I continued the tenofovir and 3TC to provide antiviral cover if efavirenz was going to be in her body for some time. I initially continued first-line TB drugs and did LFTs daily. This was 2.5 times the upper limit of normal, but that was the wrong thing to do. Her ALT and AST increased, so they had gone up to 5 times normal, which is about 150, 160, and she had to stop therapy, her TB therapy. So I stopped TB treatment. The efavirenz, I didn't feel I could reintroduce because of the possibility it was the cause of this. So once her LFT settled, she went on to raltegravir, double dose, and with the tenofovir and 3TC. She got amikacin and moxifloxacin, were started at the same time. Then ethambutol was reintroduced, then pyrazinamide. Her LFTs remained below the upper limit of normal. Amikacin she had for 8 weeks, and then she continued on the others for 6 months. Now, that isn't the standard way of reintroducing drugs by any means, but this was in somebody with hepatitis. But this is somebody who had a rash and eosinophilia too, so I think there was danger in just restarting drugs. Cetrin could have been the cause of the rash and the eosinophilia. One would never know. So I suppose, if anything else, the little discussion we've had indicates how difficult it is sometimes to tease out what is the cause of a reaction, a hypersensitivity reaction. And Cetrin, of course, could be the cause of everything in this lady. All right, then, I'll stop there. It's 5 to 7.
Do you think that's adequate?
Are we... Yeah, I mean, I know that the really enthusiastic people say, carry on. Yeah,
Okay. Do you want me to do the next one then?
No, I just got to text the person I'm meeting at 7. I'll do that at a question. Okay, this was a chap who was so sick when he came in. He was 38, 1 week of fevers, cough, dyspnea. He was in jail, and he collapsed, and he had to be intubated straight away. He was acidotic. Now, he was your typical sort of man who ends up in prison, I'm afraid to say. I mean, he wasn't, you know, one of these dealers who'd made millions on the market. He was a cocaine abuser, frequent prisoner, visits to prisons, no TB, HIV positive, Hep C negative, cotrimoxazole prophylaxis had been started as soon as he came in, CD4 count 2, and not on heart. And there's his x-ray, and my golly, you'll have these when you go to clinic tomorrow. His initial, as you can imagine, AFB 4 pluses out of 3. Sputum was PCP negative, so despite being started on cotrimoxazole and prednisolone, that was stopped, and it didn't look like PCP. Great cavities. He started parenteral anti-TB drugs that we had, INH, RIF, levofloxacin, and amikacin. He was extubated after 4 days. He was switched to oral treatment. The probe was RIF and INA sensitive. And you see him in the TB clinic and HIV clinic. His current TB treatment then was 5 days a week by DOT, which was being organized, going back to a hostel and not the prison. He'd got himself much cleaner, they mostly do in hospital, and he had some heart concerns, but he'd had heart previously, a little bit of it, efavirenz, 3-TC, and tenofovir, viral load suppression, but then he stopped taking it. So he had this history of taking standard efavirenz, 3-TC, and tenofovir, and then stopped. So you have no access to a resistance test. Now, you do have access to a resistance test. It costs a lot of money, equivalent of about $150. And so I do suppose that a lot of you are faced with this situation and you can't get a rapid resistance test. Even though you might be able to get one, it's not going to be rapid. So what would you prescribe? Would you prescribe efavirenz, given that he may well have NNRTI resistance from poor adherence? It's not going to be any good. But of course, efavirenz is the easiest thing to give when you're giving rifampicin, because you just get normal, the likelihood of getting viral load success is the same if you're giving rifampicin, giving efavirenz without rifampicin or efavirenz with rifampicin, although you do get a reduction of about 30% because of induction, and you can give a little bit extra in view of that. So we used to give 800 milligrams to people over 60 kilograms in weight, but we don't do that now. Raltegravir or dolutegravir in double dose is an option, and the last patient, that's what we did. We doubled up the raltegravir dose. Boosted PI, but then the interactions with rifampicin, and you have to use rifabutin. And this is just, you know, the DDIs between rifampicin and rifabutin showing you if you can't use rifampicin, then it's a real problem. And I don't know what the accessibility to rifabutin is here, but I'm sure it's not so easy. And of course, you can't give combined anti-TB medication, you know, single tablet regimens. So there are no questions with this. We did get the genotype back. It was 103N, so that was the efavirenz, and 184V. And the patient was successfully treated with rifabutin-based regimen, and in fact got Kaletra, tenofovir, and AZT. And we heard about resistance, and if you fail tenofovir, the possibility of having a K65. AZT is a particularly active drug. So I'm going to stop there because it's definitely 7 o'clock, 1 minute past. And are there any questions?
Any questions? No? Do you want me to?
I do think you've had a very long day. You know, it's 11 and a half hours or something, no, 10 and a half hours you've been at it. And so those of you who are still on your seat.
Ed, can I do the last one? I'll do the last one.
Yes, I'm going to go because I've got to meet
Let me do the
somebody for
last
dinner.
one.
So thank you very much for listening. And
That's all right. I'll do the last one with them. Right. 37. You better not forget your stuff. 37-year-old woman, known to be HIV positive. She has a CD4 count of 157. She was referred from somewhere else, presented to the infectious disease department, and she informed them she was diagnosed about 6 weeks ago, and all her tests and her baselines were normal. So as was routine, then she was commenced on efavirenz, tenofovir, that's your tripler, as a single treatment regimen. And you can see that there was, you know, an effect. Her viral load decreased from 780,000 to 12,000. That means over a 6-week period. But then this rebounded. Okay, we expect up to 2 log drop within 4 weeks. Okay, but in 6 weeks, there was still some virus around. what are the possible reasons for a viral load rebound? You can just shout, you don't need to. So what are the possible reasons? Say that again. Adherence, brilliant. Something else? Failure, yeah? Anything else? Because remember, we don't have a, she just said the baselines were normal, okay? Poor compliance, poor absorption, possibly some interaction. She already had a resistant virus. Concerns about pregnancy. What does that tell you? Why has this been put down? And maybe something else. Say that again? Yes. See, there was this, for a long period of time, and I mean, efavirenz, atripla, causes teratogenicity. And I've had several women who have wanted to conceive, and they haven't told us that they're stopping their drugs. They conceive, and then they turn up 8 weeks, 10 weeks pregnant. It's too late anyway. So I've left them on atripla, even though they had concerns regarding the drug. So that could be one of the reasons. And therefore, it's imperative that when we start someone, a female on treatment, we ask them, are they planning a family? And if they are, you do have to talk about atripla with them. Anyway, what had happened really with this lady was she'd lost her job, her partner had left her, she had no money, she was moving in with her sister, and her sister was unaware of her diagnosis, and therefore she'd, sort of taking it on a sort of irregular period. But now, she said that she's moved into a new flat, okay, and she's committed to taking her tablets. Okay, so therefore with this patient, you have to guess a resistance pattern. What would you do? Okay, there are two options here. Restart efavirenz, you can vote on this. Restart efavirenz as a single tablet with tenofovir 3TC, or switch her to a second line. Please vote. Okay. Tarun, do we have any luck there? Okay, so this is, so what do we have here? Switch to second line, yeah? So most of you, who said restart? Okay, do you want to save yourself? Sorry? Okay. As a single tablet, why would we restart efavirenz? It has its advantages, okay? Playing safe is the second option, that is second line treatment PI, because it's a forgiving drug, and you're not going to get wrong with it. But remember, she's promised that she's moved to a flat now, she has her own home, she's going to be compliant, and she's going to stick to her medication. Do you trust her? Yeah? I probably would. And the advantage is that you can monitor her viral load within 3 months. Rather than giving her a 6-month appointment, which we normally do, I'd probably bring her back early and see what her viral load has done, okay? The benefits with efavirenz is that the drug may still be active, you're saving your second line, which is your PI, and maybe she had side effects. Remember the presentation earlier where they talked about efavirenz causing a lot of suicidality in meta-analysis. And it's surprising the number of people, once you switch them to another drug, and they say, I mean, my patients use the word spaced out. I was totally spaced out. I didn't realize I was having side effects with efavirenz. It's a much more common side effect than people talk about. So, did she have side effects and she stopped it? Possibility, that has to be taken into account. And again, boosted PI, we are sort of certain of its activity. So there are benefits for both treatment regimens, whichever one you decide to go for. Now, which NRTI, if you were going to switch to a PI, would you use an AZT? Yes, probably yes, because it retains its hypersusceptibility even in the presence of a K65R. It's easy to give AZT3TC as a BD dose and monitor its, and probably it has fewer side effects or adverse events. Tenofovir, unlikely K65R because the viral load the patient has had treatment for only 6 weeks, remember? And you looked at their viral load. The M184 we know works better in the presence of tenofovir. It's a single tablet again, and it's well tolerated. So again, there is some advantage with option 2 using an NRTI. That's it, basically. Well, thank you for your patience and your, sitting here with us. Enjoy your evening. We'll see you tomorrow.